Good morning, everyone. Thank you for sticking it out. This is our last session of the morning sessions before we break for lunch. I'm Priyanka Chablani. I'm a GU medical oncologist at the University of Pittsburgh Medical Center. And just to give you an overview of today's session, we will do a rapid fire of 5 poster ads, which will be 2-minute presentations of noteworthy posters, and then we will jump into 4 oral abstracts, which will be longer presentations. And I do just want to put in a plug that both me and Dr. Arpita Desai will be doing poster walks at 6:30, from 6:30 to 6:50 tonight, for those of you who'd like to take a deeper dive into all the wonderful posters that we have presented today that are not going to be highlighted in this session. So with that, I'll let Dr. Xu introduce himself.
Hello, good morning. I'm Dr. Vincent Xu from Good morning. I'm Dr. Vincent Xu from Dana-Farber Cancer Institute, and I'll be co-moderating this session with Dr. Chablani. And with that, we will dive right into our poster ads.
So we'll start with Dr. Alka Vajpayan, who will, from the University of Michigan, who will be presenting a poster on lenvatinib plus pembrolizumab versus sunitinib in advanced clear cell renal cell carcinoma, patterns of progression, and subsequent therapy in the CLEAR trial.
Hi. Thank you. It is my pleasure to present on behalf of all my co-authors. I'm really standing in for Dr. Grunwald, who's the lead author on this poster, and he couldn't be here today. So clearly, all of you are aware of the CLEAR trial, which was a randomized study in advanced kidney cancer. And it randomized to 3 different arms: lenvatinib, pembrolizumab, Len-Av, and sunitinib was the control arm. The results of the study and final results were reported in JCO earlier this year. But this analysis is looking at patterns of progression and subsequent therapy in the CLEAR trial. So this is what was looked at, and this is obviously a teaser. There are details on the poster fully, but time to progression in the subsequent therapies, whether you used VEGF-TKI or and either of the VEGF-TKI, the most predominant ones were cabozantinib or axitinib that were used after progression on len-pembro. First of all, the thing that was noted on the len-pembro arm is that the bulk of disease was much less when they progressed as compared to on the sunitinib arm. But also what happened is on the second-line therapy, and as you can see, the numbers are up there with the number of people getting cabo versus axitinib. Definitely there was a significant improvement, what looked like a prolonged median PFS seen with either of these therapies on the len-pembro arm as compared to the sunitinib arm. So the patients who progressed on len-pembro appeared to be with less tumor volume and appeared to do better with the cabozantinib or axitinib, the second-line VEGF-TKI-based therapies that were used. Thank you.
Thank you, Dr. Vajpayan. And next, I would like to invite Dr. Ornstein to the podium to introduce his poster, Blood-Based Multiomics Profiling and Immune Features Associated with Response to ICI in Patients with Metastatic Renal Cell Carcinoma.
Good morning, everyone. On behalf of my co-authors, I'd like to thank the scientific committee for allowing us to share some of our data. I will try for the impossible of some single-cell RNA-seq and some single-cell secretomics in about 1.5 minutes. So we essentially ran blood-based multiomics profiling to attempt to define certain immune features that could predict for response in patients treated with ICI-based combinations for metastatic RCC. For the purposes of the poster ad, I'll describe the single-cell RNA sequencing findings as well as some single-cell secretomics. So on the left-hand side, you see the single-cell RNA sequencing. What I'd like to highlight is that we did this both at baseline and samples of patients on treatment. The key takeaway here is that the largest transcriptomic differences between responders and non-responders were seen at baseline. They were actually not seen when we looked at the same analysis for patients while they were on treatment. I'll highlight a few of the differences over here, just to highlight the allograft rejection and TNF-alpha signaling. Again, these are signals of pathways of lymphocyte activation and immune response that were seen in responders at baseline. And less so in the non-responders. In terms of the single-cell functional secretomics, again, we looked at baseline and on treatment. It's difficult in this kind of slide to highlight much of it, so I'll give you the key takeaways. In the baseline population, looking at CD8 positive T cells, we saw essentially a higher frequency of CD8 positive T cells with chemoattractive and effector functions. Conversely, in CD4 positive T cells, the main findings were seeing the difference that we saw was really a higher frequency of CD4 positive stimulatory function in terms of the secretomics while on treatment. A ton of work, there's much more on the poster, and a thanks to the collaborators and to the KCA. Thank you.
Thank you, Dr. Ornstein. Next, we'd like to introduce Dr. Abubakar Kaba from the Department of Urology at UCLA, who will be discussing his poster entitled SESTA-MIBI SPECT-CT for their characterization of solid renal masses, secondary endpoint analysis of prospective study correlating imaging to histopathology results.
Thank you. I bring you greetings from the UCLA Kidney Cancer Program headed by Dr. Brian Schuck. Our study was a prospective study in which patients were given the opportunity to have a SESTA-MIBI scan completed to see if this would change them and the provider's choice in management of their small renal masses. This secondary analysis evaluated the 93 lesions that were visibly rated by a nuclear medicine reader. We had pathology available in 61 patients who ended up getting definitive management with either surgery or radioablative therapy, and we did concordance testing on the results. This showed us that there was a sensitivity of about 78%, but a specificity of 94%, suggesting that SESTA-MIBI can non-invasively identify more indolent oncocytic lesions, and thus a positive scan may aid in selecting patients who are better candidates for active surveillance than not.
Thank you, Dr. Kaba. Next, I would like to invite Dr. Linnea Olson from UNC to present clear cell renal cell carcinoma patients with myosteatosis at diagnosis, harbor more aggressive tumors, and experience worse survival. Thank you.
Hi. I believe this is actually the wrong title.
Oh, I'm sorry.
I'm so sorry. Today, I'd like to talk to you actually about weight change around the time of diagnosis among localized RCC patients. And I'm going to wing it because I don't have my slides. So we were motivated by the obesity paradox, the observation that while obesity does increase risk of RCC, many clinical studies have reported that overweight and obese patients have improved outcomes relative to normal weight patients. So we hypothesized that normal weight patients might have some overlooked weight loss prior to diagnosis and in the peri-diagnosis period. So to investigate this, we used data from the ReLife cohort in the Netherlands, 368 patients with localized RCC. Patients were asked to report weight 2 years prior to diagnosis, at diagnosis, and at 3 time points post-diagnosis. We observed that indeed RCC patients were losing, on average, weight prior to diagnosis and in the peri-diagnosis period, but largely gained it back in the 2 years after diagnosis. We also conducted stratified analyses to look at how normal weight patients and patients with more aggressive disease had experienced weight loss in that time period, which I would love to discuss with you at the poster. Thank you very much.
Thank you, Dr. Olson. Next, we'd like to invite Professor Borje Lernberg from University of Umeå in Sweden to discuss his talk, his poster entitled Occurrence of Local Recurrences and Metastases After Ablation versus Partial Nephrectomy, a Renal Cell Carcinoma, a Real-World Competing Risk Analysis.
Thanks for your invitation to this ad. How do I move it more further? There. This is a nationwide, population-based study. All patients in the country, all those with non-metastatic renal cell carcinoma, and those that were treated with not nephron-sparing treatment, partial nephrectomy or ablative therapy. There were 2,751 patients, mean follow-up 4.8 years. We have dates of treatment, local recurrence, metastasis, or death in the register. We used a Cox regression adjusted analysis. We found around 4% of both local recurrence and distant metastasis. And we have a much higher death rate of those with local recurrence or those with distant metastasis compared with those patients without. And we could do this adjusted multivariate analysis that patients with ablative treatment compared to partial nephrectomy had 4.3 times higher risk of local recurrence, significant, and 1.9 times higher risk of distant metastasis. Thus, ablative treatment had 4.3 times higher risk of local recurrence and 1.9 times higher risk of distant metastasis. That's all. You have to look at the poster P1 for further information. Thank you very much.
Right. Thank you, Dr. Lundberg, for your presentation. I'm going to ask the presenters to switch off. We're going to save questions for the subsequent poster session. And I would like to invite the members who are presenting the oral abstracts to come to the stage. For our first oral abstract presentation, I would like to invite Dr. Alejandro Sanchez from the Huntsman Cancer Institute, who will present his oral abstract on the clonal origin of belzutifan-resistant kidney tumors in VHL disease. Thank you, Dr. Sanchez.
Hi, everyone. My name is Alejandro Sanchez. I'm a urologic oncologist at Huntsman Cancer Institute. What I'm going to present to you today is essentially a proof of concept or a sort of molecular case report of two patients that we've seen at Huntsman Cancer Institute who have been treated with belzutifan in the setting of increasing size of kidney tumors in patients with von Hippel-Lindau disease and develop resistance requiring surgery. How do I move forward here? You guys know? Okay, so I hope at the end of this talk to leave you with two key points. One is that we could use exome-derived tumor clonal trajectories to try to understand belzutifan resistance mechanisms, especially in this patient population. And two, we want to highlight the need for some multi-institutional collaboration since these patients are likely to be small numbers within individual institutions, but I think partnering with patients and with each other, we could really pull together great information and learn a little bit more about VHL disease-associated RCC belzutifan resistance. So we're all familiar with this data showing good response to belzutifan in patients with VHL-associated clear cell RCC. At the time of the 2021 New England Journal of Medicine report, the majority of patients had some degree of stable disease or response. This was at a follow-up of about 22 months. Data from the most recent abstract presented at AACR with follow-up going up to 50 months showed that indeed some patients were developing resistance to tumors. resistance to belzutifan. 16 patients underwent 18 tumor resections, of which 13 were renal cell carcinoma. Again, showing that as we treat more patients with belzutifan in this clinical setting, we'll be seeing these resistant patients with the resistant disease needing clinical management. And we can use this specific population to really try to learn as much as we can about intrinsic resistance and acquired resistance to belzutifan. So what's unique in this patient population is surgeons, we usually treat these patients either with a minimally invasive or an open surgical approach, depending on the tumors and prior history of surgeries. But we usually try to resect not only the tumor that might be progressing, but any other tumors that are present at the time that we can safely remove while maintaining the normal kidney and trying to preserve kidney function. So at a time when we remove tumors, we might find one that is resistant, one that has responded, some that have been stable. By doing exome sequencing on these different tumors, we may be able to define tumor evolution and try to assess drug resistance in certain tumors. This is just an example of a phylogenetic tree, which I'll show later, with the area circled in blue showing that they are genetically related. By studying these, we might be able to understand a little bit more about drug resistance in this population. So these are 2 patients with a total of 5 tumor sequence with for exome sequencing with a depth of 211x. We looked at mutations, copy number alterations for each patient, and then we built phylogenetic trees to understand the evolution of these tumors. We also did some basic characterizations from immunohistochemistry standpoint, and just looking at characteristics on the H&E slides. So I'll present the characteristics of the 2 patients just to kind of highlight how unique these patients are. This is a patient with a von Hippel-Lindau missense mutation. Other phenotype was hemangioblastomas and had prior surgeries for kidney cancer. Was started on belzutifan and then close to 3 years later started to have an increase in the size of one of the tumors specifically. This is an example of the biggest tumor, which grew from 2.8 centimeters to 4.4 centimeters. After noting persistent increase in size of the tumor, despite treatment with belzutifan as a multidisciplinary team, we decided to resect this tumor as well with any other tumors that could be safely removed at the time. The second patient, similar story, around close to 3 years after starting belzutifan, we saw several tumors that were growing. In the second patient, there was one tumor that specifically was responding. So we removed a total of three tumors, 2 that were progressing, 1 that was responding. This is an example of the biggest tumor. You can see here some cystic characteristics of the tumor compared to the prior patient. When we looked at the pathologic tumor characteristics, patient 1 had mostly grade 3 tumors, patient 2 grade 2 tumors. I'll just highlight that in the regressing tumor compared to the progressing tumors, there was some evidence of regression, which was characterized by dense fibrosis and edema. We did see some cystic change as well as necrosis in the tumor. And notably, there was no inflammation within the tumor, but definitely inflammation around the tumor itself. When we looked at HIF2 alpha staining, the 5 different tumors had pretty low staining overall. Looking specifically at the exome, we saw that within each patient, so the 2 tumors for patient 1 are in gray, the 3 tumors in patient 2 are in blue. They have similar overall mutational burden. With the first patient have a higher total mutational burden than patient 2, there was really no big difference between the progressing tumor and tumors and regressing tumor in patient 2. The copy alteration differences were notable between patients, but very similar within the tumors themselves, and the regressing tumor didn't really stand out as far as copy number alterations go. When we looked at tumor phylogenies, this is for patient 1. we see that they share about 74 mutations, notably an mTOR activating mutation and TERT promoter mutation. For patient 2, there were no private mutations notable private mutations in the first progressing tumor. I show some mutations of unclear consequence in the second progressive tumor. And in the regressing tumor, again, no specific notable mutations, but clear difference in terms of shared mutations compared to the progressing tumors. So by comparing these two, and especially patient 2, we can see that there is a likely shared clonal origin of the progressing tumors in patient 2 and likely separate origin of this regressing tumor. As far as next steps, we're looking for collaborators to try to identify more patients that have resistance to belzutifan in this primary setting and are requiring surgery or other treatments. Trying to do this, I think, will help us really expand what we can gather from this patient population to try to help improve outcomes. Our next steps for this cohort specifically, these patients have both actually gone on to have additional surgeries. We'll be characterizing those tumors and including RNA sequencing as well as whole genome sequencing. And then I think one thing that to me has come up in just thinking about this patient population is we need to think about how to characterize clinical progression radiographically and also pathologically compared to regressing tumors. So the two take-home messages are this is a growing population that we'll probably see in our clinics. I think we can learn a lot from this, and hopefully I showed you that the regressing tumor seems to have a different clonal origin compared to the progressing tumor, at least in patient number 2. And I think working together, partnering with patients and with each other, we can create a cohort of patients that we can learn a lot from. Thank you.
If it's okay, we'll save questions for the end so we can stay on time here. Thank you, Dr. Sanchez. Next, we'd like to introduce Chanaza Nam from Dartmouth College, who is a PhD candidate there, who will be presenting her talk entitled Differential Transcript Usage Analysis Reveals Transcript Level Changes Associated with Survival Outcomes in Clear Cell Renal Cell Carcinoma.
Hi, my name is Chanaza, and I'm a fourth-year PhD student in Lucas Salas' lab. Thank you for having me. Today, as I discuss how transcript level expression analysis and also differential transcript usage can deepen our understanding of survival outcomes in CCRCC. So we know that traditional gene expression analysis will average out expression values across all transcripts that map to the same gene. What that does is that it's going to mask critical isoform-specific details. Because through alternative splicing, a gene can have multiple isoforms, some of which could be non-functional or functional. And in terms of functionality, I'm a tall girl. In terms of functionality, these isoforms could have alternative disease-causing functions. So it's important that we resolve to the transcript level in order to see what's going on and also get novel clues for prognosticating this cancer. Okay, at the Salas lab, we are conducting a multi-omic study, which we, on samples we got from the tumor bank at Dartmouth. My work specifically focuses on transcriptomic side of things, and in particular, I am performing gene expression and transcript expression analysis with the adjustment for clinical confounders and also biological confounders in terms of cell type proportions. So with regards to my transcript level analysis, I will be focusing on differential transcript usage, which refers to looking at individual isoforms in the context of all of the transcripts that map to the same gene. So essentially, we will be looking at the individual proportions of these transcripts. Quickly, to illustrate how powerful DTU analysis can be, I'm showing results for a comparison between tumor and normal samples. And DNS1 happens to be the top gene with DTU for this comparison. And I want to show you the box plots, the bar plots below. So on average, we see that the expression values for DNS1 are lower in tumors compared to the normal samples. However, when we resolve, we see that, very interestingly, for the canonical transcript, you have the exact opposite pattern. And this is just humbling for me, because if I had stopped here, I would have called it a day and just said, probably DNS1 doesn't have a tumor-promoting function, but the canonical transcript from our DTU analysis says otherwise. Okay, we'll turn our attention to survival because it's our major focus. And here I'm showing, pardon me, oops. Okay, there we go. I'm showing results for a rather simple comparison where I'm comparing DTU in patients who survived past a year and those who didn't. And FBOX17 is one of the top genes. Again, a simple case where we just have two transcripts that map to this gene. The box plot below, we see very clearly that the transcript in gray, the proportions of this transcript are higher in patients who survived past a year, and the opposite for the transcript in maroon. The Kaplan-Meier here we had censored at 5 years to limit the influence of competing risks. So we're looking at survival probability over 5 years. And again, this is for the transcript in gray. We see from the log rank p-value that there's just basically better survival for those with higher proportions of this particular transcript. So to culminate things, I did a GSEA analysis, and these are my top hits. And on the x-axis is the gene ratio of the enriched genes to all of the genes in the relevant pathways. So super clearly, we see that catabolic processes are enriched, and it immediately makes me think about what we know about the downstream effects of VHL. We also see cell cycle pathways being enriched, and also makes me think about 5Q amplification events. But in a nutshell, we can see that pathways that we know are implicated in the biology of CCRCC are being affected by alternative splicing. Okay. In conclusion, I have shown that differential expression at the transcript level, notably of one of the top hits, FBOX17, is associated with distinct survival outcomes in RCC. And it could mean a lot of things for identifying prognostic biomarkers and therapeutic targets. In future, I want to literally take the transcripts apart and look at the proteins, their domains and interprotein regions, so I can tell exactly what's going on mechanistically with these transcripts. And I'd like to thank all the patients who generously donated their samples. Wouldn't be possible without them. And I want to thank my mentor, Lucas, Thank you. And all the members of the Christensen Lab and the funding we're lucky to have. We have posters. Like I said, we're doing a multi-omic study, so Mingui will be discussing her work on non-coding RNA as it relates to D2 analysis. I think she's on D3 and D2. I'm on A1, and I'll be sharing my work. And also we have work from Mary, who is doing all the cytosine modifications aspect of things. Thank you.
Thank you, Dr. Nam. I'll invite Dr. Ritesh Koteka to present his oral abstract. This is a description of ALLO-316 in patients with advanced or metastatic clear cell renal cell carcinoma with updated safety and efficacy from the phase 1 TRAVERSE multi-center study. Thank you, Dr. Koteka.
Thanks so much for the organizing committee for selecting this abstract. My name is Ritesh Koteka. I'm an assistant attending at Memorial Sloan Kettering. And on behalf of my co-investigators, I'm pleased to present the updated safety and efficacy results from the phase 1 TRAVERSE study, which is a first-in-human study of ALLO-316. It's clear that we have high unmet needs for patients with treatment-refractory kidney cancer. CD70 is a surface antigen that is highly expressed in clear cell RCC in most patients, and it has restricted expression in normal tissues, making it an ideal and attractive target. ALLO-316 is an investigational allogeneic CD70 CAR T-cell product, and the whole schematic, as you can see here, as a construct is displayed. It is derived from healthy donors. It is an off-the-shelf product, meaning that it can be readily available for patients after enrollment, and it is designed to recognize and kill both CD70 positive tumor cells and CD70 positive alloreactive host T cells that may lead to allorejection. This is the overall study design. As you can see here, this is a phase 1A/B, with the first portion as a 3+3 dose escalation with escalating doses of the CAR T-cell ALLO-316 with varying lymphodepletion regimens, as we'll talk about it below. This is then completed and gone into a dose expansion with the overall objective of identifying a recommended phase 2 dose and the objective of determining a CD70 tumor proportion score, or TPS, with a cutoff point for future studies. As you can see here in the schematic below, patients after screening and enrollment are treated with lymphodepletion chemotherapy. Those are days -5, 4, and 3. The lymphodepleting chemotherapies that were explored included fludarabine and cyclophosphamide with varying doses of cyclophosphamide, as noted here at FC300 and FC500, and also FCA, which was a fludarabine and cyclophosphamide with an anti-CD52 antibody. You could see that 39 patients enrolled, and at least all patients received lymphodepletion, with then subsequently 35 patients receiving ALLO-316. And then this whole consort is again broken down into those patients with known CD70 status, which included 26 patients and about 8 patients with either CD70 negative or unknown status. This is the patient demographics. This is a heavily pretreated population, and I'll draw your attention here on the left-hand side. The majority of patients included in the study that enrolled had CD70 positivity, and the majority of those patients, and a cutoff point using a tumor proportion score TPS over 50, that included the majority of patients. On the right-hand side, you could see this is a heavily pretreated population with a median line of prior therapy of 3, with a significant proportion of patients having multiple lines of therapy, and even a fraction of patients having multiple mechanisms of action, including CTLA-4, PD-1, TKI, and belzutifan. This is the overall safety data. And you can see here on the left, this is broken down into all patients, and on the right-hand side, the DL2 FC500, which was the dose expansion cohort of 80 million cells. The first thing I'll draw your attention to is the cytokine release syndrome. That's something that we, as folks that are now giving CAR T cells, are really looking at. You could see here that there's a very low incidence of actually high-grade CRS. We do see fatigue. We do see various cytopenias. And I'll draw your attention here to the AEs of special interest, including infection, where all these patients are actually treated now with antibiotics, antivirals in terms of prophylaxis, but particularly the things that we also really worry about are things like ICANS or neurotoxicity associated with CAR T cells, where in this trial we have not seen any high-grade toxicity. And also as an allogeneic product, we don't see any incidence so far of graft-versus-host disease. There are 2 DLTs that have occurred in the fludarabine cyclophosphamide allo647 cohort with 80 million cells, as noted here. From the response data, you can see here that we have been seeing encouraging response rates in patients with high CD70 expression. Now, this is just to kind of orient you. On the total cohort is displayed on the left-hand side, and then this is broken down particularly into those patients that are CD70 positive, and on the right-hand side, CD70 negative or unknown status. If you look here at the CD70 high TPS score patients, you could see that this was an overall response in 7 out of 21 patients, and particularly as outlined in the gold box, in the dose expansion cohort, again, 80 million cells at FC500, you can see here that this was an overall response seen in 50%, 3 out of 6 patients, with then a confirmed response in 2 out of 6 patients. So 2 out of 6 patients, 33%, again, in that dose expansion cohort with a high TPS score showed durable responses. This is also really easily seen here in this waterfall plot. So just as I can orient you, on the x-axis is varying degrees of lymphodepleting chemotherapy regimens, but particularly by color, on the green is TPS of CD70 status greater than or equal to 50, and again, purple is less than 50. We can see here that of those patients that have a TPS greater than or equal to 50, the majority, 76%, experience a reduction in tumor, and 33% experienced a greater than 30% reduction. In terms of durability, you can see here in this swimmer's plot, again, looking at those patients with CD70 positive tumors, we can see that there are patients that are developing quite durable responses. This is after a single infusion of CAR T cells. And I can draw your attention here to the bottom, again, to the expansion cohort, where 2 out of these patients are now having ongoing deepening responses even at months 4 and month 6 after a single infusion. I'd like to point you to the translational data that we've learned also on this study. Patients after the CAR T cell infusion, if able, undergo a tumor biopsy. And that's really for us to understand, are we seeing these CAR T cells actually traffic within the microenvironment? So you can see here on the top left, this is a graph comparison of vector copy number and by patient. And you can see here that we do see high VCN levels, particularly in tumor samples and the peripheral blood after CAR T cell infusion. On the top right, this is a schematic where you can see here in the blue, the CAR T cell infusion. And on the orange, mean host T cells that are CD70 positive or negative. And what we're seeing is that if you see the expansion in blue of the allo316, you see a decrease of these host alloreactive CD70 positive T cells. This is the so-called dagger effect, which allows them to expand and actually persist. And on the bottom right, you can see here stratified by responders versus non-responders, we see a higher degree of expansion, particularly of CAR T cells within the first month in those patients who are responders. Again, correlating with what we see from a treatment perspective. So in conclusion, we're starting to see ongoing and deepening responses in patients, particularly with high CD70 expression, as noted with a tumor proportion score greater than 50, after a single infusion of allo316. And we think that this could be a beneficial thing to explore in patients with treatment refractory disease. Particularly from the translational data, we've seen a decrease after allo316 infusion of the alloreactive host CD70 positive T cells. And we do see a demonstrated manageable safety profile compared to other highly active CAR T cell constructs. I think during the trial, we've also implemented diagnostic and management algorithms, particularly around infection, and also management, particularly around other CAR T cell related toxicities like IECHS or HLH-like syndrome from CAR T cell, again, to improve safety and tolerability. And lastly, the phase 1 TRAVERSE study then supports further evaluation of ALLO-316 in CD70-positive RCC and other CD70-positive malignancies, and enrollment at this dose expansion remains ongoing. I'd like to thank our patients, families, and caregivers. Thank you.
Thank you, Dr. Kotecha. And lastly, for our oral abstract session today, we would like to invite Dr. Hayes, who is a urologic oncology fellow at Moffitt Cancer Center in Florida, to discuss his talk entitled Validating Metastatic Organotropism of FGD1 Splice Variant in Clear Cell Renal Cell Carcinoma.
Thank you so much for your attention right before lunch. Yes, my name is Mitch Hayes. I'm a urologic oncology fellow. Really honored to be here and speak on behalf of our large team at Moffitt. Today I'm going to talk about the organotropism of FGD1 splice variant in clear cell renal cell carcinoma. I have no disclosures. The learning objectives for today are to understand that this splice variant, FGD1, is expressed in primary tumor and is associated with specific patterns of metastasis in clear cell RCC, and that it is more prevalent in bone and brain metastases when compared to other sites of disease. As many of you know, the background is that brain and bone metastases in clear cell RCC carry a poor prognosis. However, current clinical guidelines do not recommend routine bone or brain imaging in the absence of specific signs or symptoms, nor are there specific systemic treatment recommendations for patients with these sites of disease based on the location of the metastases, even though many patients with brain metastases were excluded from clinical trials that led to first-line regimens for RCC. As part of our ongoing work, our group has identified distinct RNA splice variants that, when found in primary tumor, are associated with disease progression following localized treatment. So the aim of the current study was to investigate the prevalence of the FGD1 splice variant in brain and bone metastases compared to other sites of disease, and compare the prevalence between these two groups. First, I just want to start by briefly reviewing our group's work on FGD1 splice variants. So previously, using publicly available databases, we performed a large screen of alternative splice sites in clear cell RCC, and we found 16 unique splice variants that were enriched in clear cells compared to normal tissue. Amongst these, the FGD1 splice variant was associated with also a worse brain metastasis-free survival following localized treatment when it was found in the primary tumor. The incidence of the splice variant was around 9 to 14% in the various cohorts. And in our institutional cohort, we found that the hazard ratio for developing brain metastases was around 10. So we were interested to know if there was a specific biology with the splice variant that could explain these observations. FGD1 is located on the X chromosome, and the wild-type gene produces an intracellular guanine exchange factor that activates RAS family proteins and plays a role in regulating actin cytoskeleton. In the GTEx database, the normal expression is actually highest in CNS locations, while the lowest is in kidney. Deficiency of this gene causes Scott syndrome, which results in several bony abnormalities, and it plays a role in multiple different other cancers as well in terms of prognosis, such as breast and pancreatic, and in tumorigenic models, including that of osteosarcoma. FGD1 functions have been shown to inhibit PTEN, enhance PI3 and AKT pathway, and also promote creation of the invatopodia, which is a protrusion of the cell membrane, which is actin-based and supports invasion of metastasis. Our group previously also knocked down FGD1 in a renal cell carcinoma cell line in order to observe its effect on proliferation, and indeed it did slow proliferation and also cell migration. Although the biology of the splice variant has yet to be completely elucidated, in cell lines and in one patient, we observed that the FGD splice variant is generated by a novel transcript, which is associated with acetylation of lysine 27 on histone 3, which is a known super enhancer. In silico translation also indicated that the first 169 amino acids of this splice variant are deleted, which results in an SH3 binding motif being exposed on the N-terminal. So to return to the current study, we were interested to know if this splice variant is actually also more prevalent in the metastatic samples themselves, and specifically in brain and bone metastases based off of our prior work, and FGD1's role in pathogenesis in several bony pathologies. We also wanted to again look at its role in overall survival when it is found in the primary tumor, and whether or not there is an effect on overall survival in specific subgroups that were treated with and without cabozantinib, which has been shown to have activity in patients with brain metastases. So to answer these questions, we utilized the multi-institutional Orion Avatar database, which is a collaboration of 19 cancer centers with pooled molecular data. We looked at both primary and metastatic tumors. For the sites of disease, we looked at metastatic sites specifically. We considered 3 or more reads to be positive based off of our prior work. We collected clinical and demographic data, and we used Fisher's test to compare various sites of disease and FGD1 positivities, and a post hoc analysis of pooled brain and bone metastases was compared to other sites of disease using logistic regression. As far as the survival analysis, we used Cox regression on all the patients who had available molecular data from their primary tumors to estimate the impact of SG1 splice variant on the subgroups with and without cabozantinib. Of the 1,008 patients in the cohort, 84 metastatic samples were included, amongst which there were 10 and 16 bone samples, and 44% and 50% of bone and brain metastases harbored 3 or more copies of the FG1 splice variant, compared to 23% overall, and this was statistically significant. On a grouped analysis, it was enriched in bone and brain mets that were combined, and this odds ratio was 5 compared to other sites. Of the 831 patients who had molecular data from their primary tumors, about 18% harbored the splice variant, which was slightly higher than our previous study. And this was associated with worse overall survival in the cohort. In the subset of patients who eventually went on to be treated with some sort of systemic therapy, the splice variant remained significant for overall survival. In the subgroup of patients who specifically received cabozantinib, there was no association with overall survival. So in conclusion, we found that this splice variant FGD1 is more common in bone and brain mets compared to other sites of the disease, and associated with poor overall survival when found in the primary tumor. We need additional studies in biologic models to elucidate the mechanisms of this splice variant organotropism, and we hope to conduct some multivariable survival analysis in the future to determine if there is some association with specific treatment responses for the patients that harbor these splice variants. These are my take-home points, and I have a lot of people to acknowledge patients who donated their samples to the Orion Avatar database. The first author, Alyssa Obermeyer, who could not be here today, senior author Tim Shaw, and the entire bioinformatics team at Moffitt. USF medical student Justin Miller, who helped a lot with this presentation, and Dr. Brandon Manley, who's my personal mentor, as well as all the Orion collaborators. Thank you so much.
Thank you, Dr. Hayes, and thank you especially to everyone for staying on time. That was really incredible. We do have now about 11 minutes for questions from the audience, and I see Dr. Celeste Simon, so let's start with you.
Thanks. This is for Dr. Sanchez. My impression from your presentation was that the 2 patients, at least based on immunohistochemistry, had somewhat low levels of HIF-2 alpha. Did I gather that? And yes. I just remember way back when, in some of the initial studies, that abundance of HIF-2 alpha and relative abundance of HIF-2 alpha versus HIF-1 alpha could be indicative of response, and just wondered what your thoughts were.
Yeah, I thought we would see a little bit more of a difference between the progressing and the one regressing tumor, but it seems like whatever the difference is, or genetically what's going on with this responding tumor, might be independent of HIF expression. it was a little bit lower than the progressing tumors, but nothing significant. I think we need just more numbers of these responding versus non-responding tumors.
Great, and any information on HIF-1 alpha abundance by any chance?
No, but we can look into that with the RNA sequencing. Yeah.
Thank you.
Thank you.
I also follow up for that. So the tissues, however, were post-treatment tissues, right? So we are not looking, okay.
Yes.
So did you look specifically at HIF2 alpha and HIF1 beta? I mean, usually people will use software to call mutations, but did you look at the individual reads to see whether you could detect even a low frequency mutation?
Not in these two patients. We didn't see any mutations.
But did you look yourself at the reads to see? Yeah, so I think that would be worthwhile doing.
Okay.
And possibly also biochemical assays like a proximity ligation assay to see whether the HIF complex remains or not. And in particular, if you have in the same slide a sample from a tumor that is responding and a sample from a tumor that is progressing, tumor that is responding can be a nice positive control where you expect the reduced PLA signal compared to what happens in the progressive. So it could be informative.
Okay, thank you.
Dr. Voss?
Yeah, great session. Thanks, everyone. I have a question for Dr. Kotecha. So great data, and obviously so impactful, I think, for the field to see these responses in patients with CAR T therapy. I think we've all been waiting for this for a long time. I have a question about the CD70 expression levels and grouping into the high versus low, which clearly seems to show a signal. Have you at all looked at heterogeneity of expression across different metastatic sites intra-patients? Meaning, are there patients who uniformly express high in different metastatic sites?
Yeah, it's a great question. On the trial itself, I think that's something that we're still trying to work towards. From the tissues that patients are able to have submitted, but at least from the retrospective data, at least from archival, looking at primary versus metastatic sites, it seems that CD70 expression is pretty concordant, that you do see pretty high expression in both scenarios. And we've done that now, not only just by IHC, but also transcriptomics, just retrospectively, institutionally, and also on trial data sets as well. So I don't think that we have a clear sense of difference of CD70 in particular sites. I'll also say that on the trial itself, we have seen responses not only just in primary kidney tumor, but also in metastatic sites, kind of defending that point.
Thank you. Go ahead, microphone 2.
Yeah, Matt Campbell from MD Anderson. I have two separate questions. The first one I think is a little simpler. It's for the FDG1, were there matched primary and metastatic sites, and was the splice variant present in primary as well as the metastatic site, or was this something that was developed in the metastatic site only? And then my second question is more along, as we're building the CAR T story in GU, how you guys are planning to staff. Are these going to be on your GU service? Is it going to be on the stem cell? And how are you guys going to staff up given the high level of needs that are currently required to safely take care of these patients in the immediate kind of post-CAR T setting?
Thanks for your question. So we actually looked at primary and metastatic samples separately. We actually have not done a matched analysis like same patient analysis yet, but in the primary samples, the incidence was 18%. Overall, in the metastatic sample, it was 23%, and then in the bone and brain metastasis, it was 44 and 50%.
Yeah, it'd be interesting to see if this was present in the primary and it persisted, and these are patients that we need to be potentially monitoring in a different fashion versus is this something that's a gain in these metastatic sites? So very interesting work.
Yeah, Matt, that's a really, really good point. I mean, these patients are resource intensive. At least at our site, MSK, we have our own dedicated cellular therapeutics service. And I will say that many of us from each of these disciplines, now that we're seeing CAR T cells come from so many different solid tumors, for example, myself, seeing patients in GU and also attending also on the cellular therapeutic service, compared to, I think, at your site where it's sort of a little bit more discrete, where there is sort of a dedicated transplant team, so to speak, and then there's a completely different GU team. So I would argue also from, not only from a resource intensiveness, there's a huge education and and really a whole different kind of scope of field, I would say, right? Yeah. Where there are toxicities that might actually happen quite later from the first 4 weeks or so, right, after cytokine release syndrome. And you could imagine that we are seeing CRS now with some of these more intensive immune therapies also on the GU side. And their management is completely different in terms of some of the immunosuppressants you're giving, antivirals, antibacterials. And so I think there is going to be this sense of, centers of almost expertise, so to speak, as we kind of broaden this kind of technology out. But I do think you're seeing a wave of solid tumor malignancies, not even just in kidney cancer, where this is just becoming sort of a future aspect.
Yeah, absolutely. Thank you.
Dr. Tenier?
Yeah, thank you. Great session. Follow up on that question. Matt asked Dr. Hayes about the FGD splice. Is there any connection of that splice variant with FGF? We've found in several patients with clear cell with brain metastasis overexpression of FGF in the brain. And then this is also supports the activity of lenvatinib, which is a FGF inhibitor as well, in patients with brain metastasis similar to cabozantinib. Do you have any connection of that?
We haven't looked at any correlations with the splice variant along with like bulk RNA sequencing of expression of particular genes. We did previously in our prior publication look at some common mutations and found that the FG1 splice variant is correlated with BAP1 mutations, but definitely we'll want to look at what other sort of molecular characteristics of these patients and their tumors sort of run together. So we'll take a look at that.
If I may, Vince, just a question to Dr. Kotecha. Great, very promising, again, data. In retrospect, do you think we should have treated those 8 patients with, who had CD70 negative tumors?
It's a really good point. I think with so much retrospective data in terms of CD70 status, we have to start sort of somewhere. And to Martin's question about heterogeneity, it all comes down to whether we think that the actual tissue we're testing has the actual CD70 status actually of the patient that we're treating in front of us. Some of these tissues are hard to find, and you could imagine that the CD70 status also of a patient where they had a nephrectomy 5 years ago and they're presenting now sort of 3rd line, 4th line treatment, that might not be the same CD70 status either. So I think now going back, finding true benchmarks is really, really important, and it might be almost construct dependent as well. But I think this is also a call a little bit to some of the other CD70 trials that are potentially going to go on as well in terms of how do we understand what is the right cutoff for potential activity.
Dr. Paul.
Thanks. I was just going to dovetail on Matt's question to you, Ritesh, around infrastructure. And I think it's an important opportunity to reiterate the fact that the toxicities that we are encountering with CAR T is extremely different from what we're running into with conventional therapies. And I've talked to many investigators around the room who are contemplating opening protocols like this. And, my advice to them is ensure that you have an incredibly robust hematology team with lots of experience in CAR T who can help you guide management. I think that's absolutely a must in this context. I enrolled the first patient on the Allogene study that you presented and worked very closely with Sam Rashor at the time, who is at MD Anderson. That's Matt and Nazar's colleague that runs a lot of their CAR T programs, and got tons of great advice from him in the process around how to manage toxicity. But without that helping hand along the way, it's very, very difficult to run these studies.
I would echo that. I mean, I will say that, particularly having our own dedicated cell therapy service that's on the inpatient side, I rely a lot on my BMT, heme colleagues, whenever we're sort of encountering things and to learn from that too.
Dr. Garmezi?
Yeah, thank you. Whoa. Ben Garmezi, Sarah Cannon. Following in on the CAR T conversation, I think that was a really nice presentation, again, showing the promise of durability in some of these assets that we've seen before on other programs that were presented. But I do think there was a little bit of glossing over on the toxicity slide, and I think we could all learn a little bit from the toxicity on this program. I saw 3 grade 5 adverse events. I was just hoping that we could get a little bit more detail on those events so that we can put that into the context with the relative efficacy that we're seeing.
Sure, yeah. I mean, it's a very short presentation time here, but if I remember correctly, the 3 grade 5 events were due to potential infection, and the cardiogenic shock that was seen was also thought to be maybe related to CRS in terms of also infection as well. I do think that as we get forward, in CAR T-cell world, you can imagine that, some of the open questions, particularly with CD70, is, are you actually inducing some functional lymphopenia by actually targeting an antigen that's also on activated lymphocytes? And I think over time, as we sort of probably more prepare patients in terms of anti-infection prophylaxis, antiviral prophylaxis, doing a better job in terms of monitoring some of these patients also from reactivation. We've seen that at least at MSK in terms of solid tumor programs across the board, where we're trying to be a little bit more, I would say, honing into what is the actual type of strategy that can help these types of patients. I think that's going to be really, really helpful going forward. But I think your point is well taken. And to really dovetail also on Monty's point also, this is a completely different sort of frontier, right? These are not toxicities that we're used to looking at in terms of comparing it to standard treatments that we give in kidney cancer. I mean, it's a completely different frontier.
No, I think that's a great point, and I hope that, the investigators as well as Allogene are willing to share what they learn about infection prophylaxis, if truly all the grade 5 events were somewhat related to that, so that we can borrow from that knowledge as we expand in other programs with CD70 CAR T and other targets in renal cell. Thanks.
I think to your also point, Ben, at least at the poster, there's going to be more actually management guidelines on also IECHS, which is HLH-like syndrome, which we're seeing actually now much more CAR T cells, and I think it's just because you're seeing more active products entering the field. And so I know that at the SITC poster, which is, again, sort of companion to this presentation, there's going to be actually, I think, more formal guidance in terms of using agents like ruxolitinib, using agents like emapalumab, that all of us at our own institutions have our own institutional guidelines in terms of access and using. But you're right, standardizing some of those, not only from a diagnostic, but also a management perspective, will be helpful for everyone.
We have time for one more question, and then we'll need to break for lunch. Dr. Paul?
Oh, maybe just a comment. I was just going to say, in response to what Ben had brought up, it's easy to sort of lump together all these CD70-directed CAR Ts, but I definitely think they're so distinct in terms of their tox profile. I certainly think we can learn a lot from management across these protocols, but, for instance, we had, the CTX130 data that we presented here a couple of years ago, and tox profile there was pretty minimal. I mean, we elicited very little CRS. Maybe that's why we didn't see a ton in the way of responses as well. That could be, one explanation. But, now there's a next generation of that compound, CTX131, that's in phase 1. And I think what I'm appreciating after having been involved in a lot of these programs is that, the spectrum of toxicity is just incredibly diverse.
I think that it is going to be one where looking at that across the board, will be helpful.
Thank you for just one comment.
Please.
We cannot leave the room for lunch without saying, for people like myself who've been in this field 45 years, the field of allogeneic transplantation in patients with aplastic anemia and acute leukemia started like CAR T now in solid tumors. There were a lot of toxicities, so we really, we need to make sure we have detailed toxicity evaluation and mitigation of these, but we cannot be discouraged. I think every company that's really exploring, and every site and every investigator that's enrolling patients, talking to patients about enrolling them on these CAR T trials should be commended. We really need to do that. That's the future. The future is here today, and I'm really a very strong proponent of continuing this path to really, those patients have no other options. Many of those patients that we enrolled on the Traverse are my patients who had received 6 prior lines of therapy. They had no other option. So yes, toxicity, even if we have fatalities, but that's how the field started with acute leukemia and aplastic anemia, in the late 70s and 80s. And here we are, we cure acute leukemias, So kudos to the investigators, Ritesh, and all the presenters. Thank you for that wonderful session.
Thank you.